Welcome to the recorded version of Caring for Someone with Alzheimer's, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Home Instead Senior Care.
Our presenter today is going to be Dr. Amy Dupree. Dr. Dupree is a gerontological social worker and an internationally renowned expert on lifestyle issues relating to caregiving, retirement, aging, and family dynamics. Dr. Amy is president of Essential Conversations, Inc. and Dr. Amy, Inc., a company dedicated to family caregiver wellness. Dr. Dupree holds a PhD and master's in social work, specializing in gerontology, and earned her CSA, a designation for which she also trains others as part of their accreditation. Dr. Amy Dupree is a much sought-after speaker at corporate and professional events on the topics of caregiving, aging, and retirement, and she is a frequent guest on radio and television. And with that, I would like to turn the floor over to our presenter, Dr. Amy Dupree. Welcome.
Well, thanks, Steve. I appreciate that. And I'm really glad to be here today talking about this topic because this is a topic, as we know, that impacts so many families. And throughout my career, I've had the great opportunity to work with families who are really wanting to cope better with this issue, with their older parent that may have dementia or with their spouse who may have dementia. And certainly even with the folks, more and more now we work with the actual person with dementia to have better quality of life. For early in my career, we didn't even think about those sort of things. And today, of course, we know that people can have wonderful quality of life with dementia for a long time. And last week I had the great opportunity to keynote at the Northeast New York Alzheimer's Association conference, where they had a fabulous turnout of families really seeking more information and support. And hopefully today, all of us on the line will walk away with something that helps us better help families. And during the Q&A session, I'm sure that many of you will ask questions and offer things that will inspire each other. So let's get started. When we look at this slide, you see that, according to research, this is from the Indiana School of Medicine, by the time we reach the age of 65 or more, a quarter of us may be wrestling with failing memory and other mild cognitive problems. Doesn't have to be full-blown dementia. Many people I know you hear joke about, oh, I've got ALZHEIME'S disease, but nobody's really laughing or joking if the cognitive impairment strikes their parent or another family member. Often that laughter really turns to fear. Now, as you know, the good news is that not all signs of cognitive impairment mean that someone has Alzheimer's disease. Many health issues, even something as simple as a vitamin deficiency, can lead to cognitive impairment. And in some cases, the symptoms are reversible. And we also know that there really are activities that can both prevent cognitive issues as well as improve cognitive functioning if someone does have a cognitive disability. So with that as a background, let's go over what we're going to discuss today in this webinar. Today, what I'm going to do is first I'll start, obviously, by giving you the definition of cognitive dysfunction and the symptoms that might demonstrate that you have a client that's suffering from some of its effects. And then I'll also talk about some of the problems and the causes of cognitive issues, including those related to Alzheimer's disease and other dementia. And then lastly, I'm going to give you some ways to help your older clients and their families cope better with cognitive impairments. Because as we know, this doesn't just impact the person who has the issue, it impacts their whole family. So let's start by talking about the definition and the symptoms of cognitive impairment. First, let's talk about what cognition is. Let's start with that. So the definition of the word cognition means the process of knowing. And as you can see there, it includes aspects that you see, such as reasoning, awareness, perception, knowledge, intuition, and also judgment. Cognitive skills are really the mental capabilities that we have that allows us to process all the information we receive from our five senses. These skills are what we need in order to be able to think, to talk, to learn, to read. There's what gives us the ability to recall things from memory. Cognitive skills are also needed to analyze images and sounds. They help us maintain our concentration and draw associations from various pieces of information. Now, let's talk about what all that means practically. You know what this is really about? It's really about the ability to function in the day-to-day world. For example, if someone's having difficulty processing information from what they see or hear or taste or touch, it can really be a problem just getting through the day. And, we don't usually stop and think about this, but it really is how we get through our life and our world. We're always processing information from our senses. So when you're enjoying a really good meal, obviously you're processing what you're tasting and smelling. When you touch a hot stove and you pull your hand away, you're processing from touch. And when you're driving, you're processing lots and lots of information visually. So again, although we don't step back and think, which sense am I processing from, we know that's going on. So given that background of that's what cognition is, let's take a look at what happens when our processing gets faulty because of cognitive problems. Cognitive problems, which are also referred to as cognitive deficits or dysfunctions, occur when someone has difficulty processing information that we just talked about. And this includes mental tasks such as attention, thinking, language, emotional behavior, and memory. Now, you see there in the second bullet point, mild cognitive impairment, or what's abbreviated as MCI, is something that lies between normal forgetfulness due to aging and the development of dementia. In general, those symptoms don't interfere with everyday activities, but they do include, though, forgetting recent events or conversations, difficulty multitasking or solving problems, taking longer to perform more difficult mental activities. I think what the key here is to know about MCI is that we now know that a high percentage of people who have that do develop full-blown dementia later. And there's research going on right now that you may be aware of that's really looking just how we find, if you will, dementia earlier before we see its full-blown symptoms so that we can hopefully stop its progression. Okay, then the more serious type of cognitive dysfunction is clearly dementia. And dementia is the loss of cognitive functioning and intellectual reasoning, and that's due to the changes that are going on in the brain caused by disease. Those with dementia tend to, repeat questions or become disoriented in familiar places. Frequently, they neglect their personal hygiene or nutrition or get confused about people or time. When we talk about Alzheimer's disease, we're talking about the leading cause of dementia. It accounts for about 2/3 of the cases of dementia. And a lot of times, as you know, families really struggle with what's the difference between dementia and Alzheimer's disease. And one of the ways that I always explain this to people is to talk about dementia being the umbrella, if you will, the thing that is includes many different types of or causes of dementia. And Alzheimer's is one of those. It's the leading one. It's the most frequent with 2/3, but it's not the only one. And certainly some of those are reversible and others are more impactful. And I think it's helpful for people to know not everything is Alzheimer's disease, because if we really help our clients and families know this, I think they'll be more apt to get proper assessment. And we don't want everybody assuming they've got Alzheimer's when they have symptoms of dementia, because then they may not get the treatment they need. Okay, having said that, let's take a look now at the symptoms of dementia in more detail. Many of us find ourselves forgetting things. If you're on this call today and you're over the age of 40, chances are you're finding that maybe that happens more frequently than it did in the past. And that makes some people worry about having dementia when they start hearing the symptoms. However, just forgetting is not dementia. And I think the key is to remember that for many of us, it's the fact that we're multitasking so many things that makes us forgetful. And when I worked at a geriatric assessment clinic early in my career, which assessed people for cognitive issues, and we used to say to families that the difference between normal forgetting and dementia is the difference between losing your keys and holding your keys in your hand and no longer knowing what to do with them. That it isn't just about forgetting more. It really is a qualitative difference. And I think that's the thing that we want to help families understand. And obviously you see on the screen a lot of other symptoms of dementia. I think as we work with older adults, it's good to be familiar with these symptoms ourselves and, of course, to share them with families who have more time with the older person and may catch them sooner. Usually people aren't fully assessed or treated for dementia until they've had it for several years. And that's because the symptoms can be so subtle and hard to pick up on. So let's talk about some of these symptoms in more detail, because becoming disoriented, for example, what does that really mean? In the beginning stages, that can be very subtle. I saw this. My father lived to be 85, and he was cognitively intact, I believe, although in the last couple of years of my dad's life, I started to notice some things that did make me concerned and made me wonder if my father was just beginning to develop dementia. And one of the things I've noticed with him was this issue of mild disorientation. So I'll give you a couple of examples of it here. One time he and I I drove him somewhere, and we got out of the car, and it was a place he was very familiar with. And when I got out, he was clearly a bit confused, and he said, "Now, how did we get here? What were the roads we took?" Here's the thing that often happens for families, and this was true for me too. My father did not just have that issue. He had macular degeneration that really impacted his vision. So with his disorientation, what I never was sure was how much of it was visually caused, but in fact he couldn't see very well, and so he was saying, how did we get here? Because he was trying to remember because he couldn't see it, versus I can't process that in my brain anymore. So that's the kind of thing that families usually don't tune into early on, because it is very, very subtle. But I know in working with families, and I'm sure you do too, that when they eventually, someone does get assessed and does get diagnosed with dementia, or more specifically with Alzheimer's, that they'll say, I remember a few years ago, Mom started doing this. And they start being able to recount things that at the time didn't seem like a big deal, and it wasn't until they continued over a period of time that they really understood the problem. Okay, so language problems. This is can be just trouble finding the name of familiar objects. Now, again, many people as they age have this, and one of the things we're learning more and more is we really do need to exercise our brain. We're going to talk about this later, about physical exercise and mental exercise, but we do need to exercise our brains, and we need to do it in very specific ways. It's not just doing crossword puzzles. And for many of us, we start to lose some of these word-finding things as we get older, but again, it becomes much more severe with dementia, and it's qualitatively different. Misplacing items. Now, this isn't when you walk around the house and you've got your reading glasses on top of your head. That happens to many of us. This is really, or you can't find your keys. This is if you open your refrigerator and you find your running shoes. That's a problem, okay? Because that is putting things in places that clearly they don't go. That's the kind of thing you hear people talk about a lot. I'm reading a wonderful book right now, and this called The 5 Life Lessons from the Dying. And this woman talks about caring for this older woman who has dementia, who loses her teeth constantly. And they're forever looking around the house, and they'll find them, behind the couch cushions, or she's tucked them somewhere. But it's kind of this game of always looking for the teeth. That's what we're talking about. Personality changes. Again, this is often something that when people look back, they start to notice. So I think if we can get people tuned into the subtle personality changes, somebody becoming uncharacteristically irritable or angry is sometimes a sign that we see early on when that happens continually. Losing interest in things someone once enjoyed. And a lot of times now we realize that that's because they can't process it. They're overstimulated, they can't process it. Difficulty performing tasks that take some thought, but that used to come easily. For example, balancing a checkbook is an example of that, or playing a game that someone used to play, or doing a task that might have multiple steps like cooking, but something that somebody has done pretty well in the past with no issues, and then suddenly they can't quite remember how to do it. Forgetting details about current events. This is a little harder to pinpoint because many of us do this as we get older. And again, a lot of times that's because we're carrying so much in our brains that it's difficult. But certainly now we're getting into more serious symptoms here, losing awareness of who you are. As people move through, especially with Alzheimer's, they move into later stages. They start to recognize themselves as a distinct individual, as well as recognizing other people. And then changing sleep patterns often becomes a sign that someone has dementia. The difficulty reading or writing, again, if you think about that, you're processing visually when you do that, so it makes sense. Displaying poor judgment, it can be a big issue for people. they start to have a very difficult time with that. They may do something like walk out into the street when a car is coming, something they wouldn't have done in the past. They don't recognize danger in a situation. They leave on the stove. Back when I was in college and was caring for an older woman with dementia, I was on a week-on, week-off shift for during the summer, this one summer, and I woke up one morning and this woman was boiling orange juice. Poor judgment. Again, becoming easily upset, we know that that's a sign. And I think, again, we're going to talk about social withdrawal, and social withdrawal is often a big issue for people. They start to pull back socially, and again, one of the things that we often see early on. Now, there's a few other symptoms not listed there that I'm just going to go over with you just as a reminder. Obviously, later on, when people start having hallucinations and arguments and being violent or striking out, that's a problem. If they're having delusions, depression, we're going to talk about depression because depression is often misdiagnosed as dementia. Agitation, the idea about becoming easily upset when they're out of their comfort zone. So the comfort zone gets smaller, might be, first being in familiar places outside the home, and then may just be in the home, and then may disappear from there too. And clearly incontinence and swallowing problems. Recognizing any of these symptoms, even the mild one, are a reason for concern. And the quicker we can encourage people to get help, the better. The more likely that they may be able to extend the quality of life of either themselves, if it's them, or of someone that they love. Early intervention really does matter, so we really need to encourage people to have a full assessment. Okay, so now I'll provide some background on the potential causes of cognitive issues. So not all cognitive impairment, as we said, is a result of Alzheimer's disease or other dementias. You see, their stress, anxiety, and fatigue have been found to cause memory loss, and I'm sure many of us have had that happen, and when you're under highly stressful situations and you just can't pull up a word or something's going on. Studies have also shown that men with elevated levels of the stress hormone epinephrine are more likely to suffer from mild cognitive impairment than are their peers who have normal levels. Another study showed that everyday stress combined with major stressful events may exert a cumulative effect over a lifetime that can exacerbate cognitive decline. Many of our parents who suffer from diseases associated with aging, such as cancer or heart disease, may end up with cognitive dysfunction as a result of treatment of these conditions. And I actually know someone right now whose parent is going through this. She was treated for cancer, and she is now showing significant signs of dementia, and they believe that this was the treatment for the cancer that may have been exacerbated this with her. At Duke University Medical Center, researchers found that 2 years after major non-cardiac surgery, 42% of older patients will have experienced a measurable cognitive decline. I thought that was a very interesting fact. I had not heard that one before. And then again, the cancer treatments are a common cause of cognitive problems. If you want to look at this more, cancer.net reports that approximately 20% of people who undergo chemotherapy will experience some cognitive problem side effects. Radiation treatment to the head or neck is also known to cause cognitive problems. And other conditions or symptoms related to cancer or cancer treatments like anemia, fatigue, stress, depression, insomnia, high blood calcium, and electrolyte imbalances can also result in cognitive dysfunctions. Other causes of cognitive dysfunction include, I want to talk more about the infection, actually, so let me come back to that because I just mentioned that. But one of the most common causes of cognitive issues is something as simple as a urinary tract infection. And many families don't know that, so we really need to inform families about that. I'm sure many of you on the phone know that the first symptom of a urinary tract infection for many, many people is, in older age, is actually confusion. And families often miss that. I actually was doing a speaking engagement one time, and it mentioned that, and a gentleman came up to me and said his mother-in-law had died from a urinary tract infection because it was misdiagnosed because the family had assumed that it was dementia. So I think, again, anything we can do to educate families about these things are very important. I think the bottom line we want to say here is dementia can be caused by many, many things, some of which are reversible, such as the vitamin deficiencies, the UTIs, the poor nutrition, reactions to medications, those sort of things, or even problems with thyroid. And then, of course, some forms of dementia are irreversible, such as those caused by strokes or mini strokes, Alzheimer's. And my mother had dementia from a stroke. It wasn't mini strokes. My mother had a massive stroke, and she could really no longer process very well after that stroke. And my mom lived about 8 years after that, and many of the same communication techniques and ability to work with my mom that I have used with people who have Alzheimer's, we used with my mother who'd had the stroke because she really struggled with this. So I think, again, recognizing that families need this education because it's hard to know what to do when your family member has this if we don't teach them. And so one time with my mother, I had this kind of funny experience happen. I was there in the afternoon, and I made my mother and myself a cup of tea, and I sat in the living room with her. And I have to tell you that one of the lovely things about my mother was that she was always delightful and in a good mood. So she didn't have a lot of the mood changes that often go with stroke that are not very pleasant. So she and I were having tea, and she just took the teacup and very slowly poured the tea on the living room rug, and had no idea, of course, why she'd done that. And I laughed, and she laughed, and I said, "What are you doing?" And she said, she'd also lost a lot of speech, and she just kind of shrugged her shoulders, and, I cleaned it up, and she laughed, and I made her another cup of tea, and she drank it. Obviously, problems processing. And I think, again, whether it's somebody who has Alzheimer's, somebody who has dementia from a stroke, families don't know how to deal with this, and we really, really need to help them with this. Okay, talking about Alzheimer's disease a little bit more here. This occurs when the nerve cells deteriorate in the brain due to a buildup of plaques and tangles. And we know that that's really the key about Alzheimer's disease, these plaques and tangles. And what happens with those is it actually results in the death of a large number of brain cells. So these plaques and tangles kind of strangle, if you will, and kill the brain cells. Doctors don't know why this happens. Research is obviously underway to try to determine the cause and hopefully the cure for this. According to the Alzheimer's Association, 4.5 million Americans are right now living with Alzheimer's disease. And we know the statistics are very scary when we look at the baby boomers aging. Kenneth Dykewald last year, I heard him talk, and he said, which really drove home, I think, to the audience, by the time we're 85, about 1 out of 2 of us will have Alzheimer's disease. And when we hear those numbers and see the percentage of baby boomers, I think the better educated we can be and the better educated we can help families be, the more likely we are to have higher quality of life for everyone who is coping with this. Now, as you know, it's really important for us as professionals to convey to our clients and their families that developing Alzheimer's disease is definitely not a normal part of aging. And a lot of people think you get old, you get Alzheimer's. We know that's not true, but we need to tell people that. Even though the causes of Alzheimer's disease are not entirely known, they are thought to include both genetic and environmental factors. So a diagnosis of Alzheimer's disease is made when certain symptoms are present and by ruling out other causes of dementia and cognitive dysfunction. And again, one of the ones I want to mention here is the idea of depression, because depression and dementia share 2/3 of symptoms. So if you made a list of all the symptoms of depression and all the symptoms of dementia, 2/3 would be similar. And this is why in older adults, depression often gets misdiagnosed as dementia, because many people don't realize that, and many people assume older people, it must be dementia. So we really have to encourage families, I think, to make sure they get that full assessment. Okay, so regardless of the causes of someone's cognitive dysfunction, what we really want to talk about is how do we support families so they can better cope with an aging parent's cognitive problems. Okay, so we all know that caregiving for an aging parent can be very challenging. But if you add in the symptoms of increased forgetfulness, absent-minded behavior, if you add in personality changes that occur with dementia, this really can become a daunting task for many, many families. So where do we go to support families? How do we do this well? Well, as a starting point, what we really need to do is to recommend to families that they consult with doctors for a full assessment. And I think what's key here is that it's not just going to the family doctor for, a checkup. This means that people really need to make sure that they're getting a full assessment that likely will include neurological testing, that will include things like rule out depression, so that families make sure that the diagnosis they get is accurate and hasn't left things out. Of course, we're at that point, once there is a diagnosis after an assessment, then what people need is a course of treatment. They need to know, how do we deal with this? Now, the course of treatment, as you know, can vary. It can be a combination of medications, of activities. What I'm going to talk about today is not the medications, but what we want to talk with is how can you and I help families better cope with this? What are some things that they can do? So here's one thing they can do. Encourage written cues. This may seem very simple, but it really works very well. So this means encourage both the person who has, especially in early stage dementia, encourage them to keep track of everything by writing it down, whether it's appointments, activities, important dates, and then make sure they keep an address book, a date book, a calendar, make sure it's visible. As a matter of fact, we really can suggest that people write down every new piece of information. They can keep a small notebook that they carry with them in a pocket or a purse, so they have it by at a doctor's appointment. They have it by the phone. And you know what, we can encourage them to use not just words, but also pictures, if that helps them understand or remember the concept later on. Doing this can really help people stay independent a long period of time. Another thing we can do is encourage our clients with dementia to make sure they ask people to repeat information. You know, none of us likes to appear silly or inept, so many times people will not ask someone to repeat information. If a client's suffering from cognitive impairment, we really may need to encourage them and tell them it's okay to ask someone to repeat something. Better that you do that. Sticky notes are also very helpful for families to leave small reminders for their parents with dementia. For example, if they forget how to use the coffee machine, write the instructions down on a note and stick it right on the machine. That's a perfect example, by the way, of something in early stage dementia that we see, people starting to forget how to do the basic tasks, and we can help families keep people independent a lot longer if we give them this kind of advice, because without that, people do start to have a hard time functioning in their home. People can also improve their cognitive functioning through two forms of exercise, and I mentioned this earlier, mental exercise and physical. You know, just like our physical muscles, we know we need to exercise our brains, and we know this more than ever. The more we exercise, the better it is, both our brains and our bodies, the better it is for our brain. You know, there's a saying now that whatever's good for our heart is good for our brain. And then add to that the mental exercise that we know and we need to do, and we'll be able to process and remember information better and longer. One way to stimulate the brain is through novelty and sensory stimulation. So, for example, someone who has a regular route through the grocery store or to the mailbox, what you can do is you can suggest they try a different route, simply go a different direction. If they can't leave the house, suggest a variation in their routine, something like using the non-dominant hand to brush their teeth, wearing a watch on the opposite wrist, showering and showering, you know, many of us are in a routine in the way we shower, altering that routine. Anything that gets us out of the routine means that we have novelty and it stimulates our brain more. So I think all of us should also take note of the fact that daily physical activity is really recommended in order to reduce the risk of developing cognitive problems. So I think that's probably something all of us could do more of, and again, excellent for the brain. One of the great things about physical activity is that there's so many ways we can encourage people to engage in it. It doesn't have to be that they're running a marathon. Just raking the leaves, taking the stairs, brisk walking, things that people can do on a regular basis. Now, if an older adult is confined to a chair for much of the day, try to find ways to encourage movement in their life. And so, again, talk to the family about this, talk to your client about this. Could be things like doing leg lifts, grasping a tennis ball, swirling scarves in the air to exercise arm muscles. Move, move, move is the key. Now, since stress and anxiety also increase cognitive dysfunction, it's important to encourage both our older client and their family to stay calm when their memory does fail. If someone becomes nervous every time he or she can't remember something, what we need to do is help them recognize that they need to relax, they need to calm down, they need to recognize that getting agitated only makes that worse. The other two bullet points you have there about redirecting during challenging behavior. You know, families often need help doing this. I think it is such a natural tendency when someone we love behaves in ways that are out of character from how we've known most of our lives, that what we want to do is shake them out of it. And I don't mean physically shake them out of it. I mean mentally shake them out of it. That we think if we just correct them enough, they'll get it. And what we know, of course, is that doesn't work. And so redirecting can often work, or moving the person out of that environment for a period of time. You know, I'm going to mention this resource again when we get to resources, but I want to mention it here because it's such a great resource. On caregiverstress.com, there's now a series of educational videos for families on how to better manage these challenging behaviors, how to do the redirection, how to manage when someone gets agitated and angry. And they're very short. They're a couple of minutes, and they're chock full of really good information how to do this simply. I know what comes to my mind is a story about my mother. And my mother was back home with my father after a year in a rehab facility after her stroke. And my father was a fabulous caregiver to my mother. He was very patient and very gentle, but my father would get frustrated sometimes. And one of the things that really struck me was something I had seen with clients forever, but it was interesting to see it with my dad. I think we need to remember that the families we work with see the person with dementia through a lifelong lens. It's as if they're watching a movie, and this is another scene in the movie, whereas professionals come in when the person has dementia, and we only get a snapshot. We don't get the movie. And so people continue to relate to the person with dementia, often as they did when the person was cognitively intact. So one of the things that would happen with my parents was my father would make soup and sandwiches for dinner. And every night he did this, but he rotated what the soup was every night, and he rotated what the sandwich was. And so on the rotation was a vegetable soup. And for reasons that I do not understand, about every third or fourth time he served this vegetable soup, my mother would spend the dinner spooning out the vegetables and putting them on her napkin next to her. Well, this drove my father crazy. And he would say, when I was there, I witnessed this a couple times. He'd say, Alice, eat those vegetables. You need those vegetables. He would go on and on. She'd just laugh. And he had a whole theory about this. And his theory, I jokingly called it his vegetable soup theory, was that because my mother had been such a strong, independent woman, and she had lost all of that in the stroke, that this was something that she had control over, that she could take those vegetables out, and that she knew it bugged him. This was part of the theory that amused me. He said, she knows that bothers me. And he said, I think it's her way of having control when she has no control. Now, I have to tell you that my mother's cognitive functioning was pretty limited. I did not get any of that from her behavior. I don't know why she did it. But it illustrated for me what families tend to do. They look at this lifelong lens. He would talk about my mother, how she had been, and how this illustrated that old part of her personality. So I think when we're working with families, we need to be very aware of that and very gentle with it, and also remind them that things have shifted. And redirecting can be very helpful, or changing the situation. One time I was there and my mother was refusing to eat, and my father was trying to cajole her to eat. And I just said to him, smiled and said, I'll take care of it. And I picked up her plate. I put it back in the kitchen. I said, seems like you're done, Mom. And she said, yep. And so then about 5 minutes later, I brought the plate back out, sat it in front of her, and she completely ate the meal. I think that's the kind of thing we have to teach families to do, very simple things that really, really work well. Okay, speaking of all this with families, let's spend just a few minutes talking about some communication tips we can share with families. Oh, well, I'm sorry. I missed a point. Steve, will you go back just one for me, please? I didn't talk about the life story as a guide, and this is a really key thing. We know that if we can teach families to go back and see who that person used to be in a very positive way. What were the things they loved? What were aspects of their life that were important to them? And even to record some of those is really key, but to use their life story as a guide today to how to work with them. So there are some wonderful stories about this, about people who lived on farms, and a woman who every day, got up every day and did chores through most of her life because she lived on a farm. And at this stage with dementia, she was refusing to get out of bed. And so her family member who was taking care of her would say, it's time to get up and do the chores. And that would get her up because that was part of her memory, her life story. And we'll tell you a couple more stories about this probably during question and answer. But I think, again, using life story as a guide to how to manage difficult behaviors today is something that would be very helpful to teach families, and that is in one of the videos on caregiverstress.com. Okay, Steve, sorry about that. We'll move forward to the next slide. Communication tips are things that we can share with families to help them better cope with what's happening with a cognitively impaired loved one. So the National Institute on Aging has developed a list of recommendations, and these are the recommendations they have. The first thing it says is to try to address the person directly and use simple, direct wording. I think this is key, and when we talk about addressing the person directly, I found I had to do this with my mother and getting her attention. So when I was visiting, if I was in the living room with both of my parents and the phone rang and my father took a phone call, my mother could not attend to me then. There was too much stimulation. And I often found what I had to do in any situation was stop before talking to her and say, Mom, and get her attention and wait till she made eye contact and then address her very specifically and directly. Otherwise, she often couldn't attend to what was going on. Very true when I've worked with folks with Alzheimer's. We have to slow it down, get their attention. It says speak distinctly and at the natural rate of speed. One of the things we know is that, again, the processing speed of someone with dementia is slower. So we want to talk naturally, but we want to speak slowly enough that people can get the messages and distinctly enough that they can get the messages. We may need to explain why we're talking, why we're there, who we are over and over again, and family members may need to do this. And of course, we know this is what's so hard for them. And we need to remind them to do all these things and to be very slow. One of the things we don't have on this slide, but it's important too, is to approach someone from the front. We know that people with dementia have a very strong startle reflex. So we need to come to them from the front. Supporting and reassuring the person with dementia, an appropriate touch on the hand, something that says, I'm here. Smiling, a lot of facial expression makes a difference. Being reassuring in our facial expression can make a huge difference. Acknowledging when responses are correct, and if the person gropes for a word, gently providing assistance so that they're not struggling. Again, sometimes family members have a hard time with this, and they want to almost talk the person out of their dementia. And then it says one question, instruction, or statement at a time. When I was with my mother and helping to transfer my mother from the wheelchair that she was in during the day to bed, I found that I had to give her one instruction at a time or she could in no way follow me. So I'd have to say, Mom, put your hand on my shoulder. And after she did that, I'd say, put your foot on the floor. And then I'd say, okay, 1, 2, 3, we're going to get up. If I said, put your hand on my shoulder and your foot on the floor, she would just look at me. And I'm sure many of you who've worked with people with dementia have seen this happen. So these are tips that we can share with families that will make everyone's lives easier. Now, it's also likely that families will need support from lots of people, other family members, friends, professionals, to help care for their aging relative who has dementia. I think as professionals, one of the greatest gifts we can give them is to talk to them about making sure they get this assistance and they take time for themselves. We know this is emotionally and physically wearing on families, and I think as professionals we really could best serve families if we support them in getting both the task help they need, the very direct help, as well as the support they need emotionally. I often talk with people about the difference between running a sprint and a marathon, that it's very different skills. And we know that when someone has dementia, we're dealing with a marathon. And so we need to be very conscious of helping families have the capacity to go the distance. They need that time. And again, I think, if you think about Ronald Reagan's daughter wrote the book, The Long Goodbye, we have to remember how much families are grieving during this process. They can't believe what's happening, and they're slowly, every day, losing a piece of someone they love. And so as professionals, I think we need to acknowledge that loss and help people have the support to really grieve and move through. Okay, so let's talk about some resources that we can recommend to families. Clearly, the Alzheimer's Association, and that's a starting point for everyone. And the ALZ.org website, fabulous place to go, and you can click on your community, get local help. We really need to get families connected with the Alzheimer's Association early on. We need to help them get to support groups if that is what they want and need, and certainly to get the help they need on a practical level. And then we have the Alzheimer's Disease Education and Referral Center. They're through the National Institute on Aging. It's a wonderful website. I really recommend that as well. And then I've mentioned caregiverstress.com. There are a number of resources on caregiverstress.com that are useful, and in the search box you can just put in Alzheimer's disease and many, many things will come up. Okay, so now let's talk about the next steps after today. Where do we go from here? I think the thing we all need to ask ourselves is, who do we need to be helping? Which client? Who needs more information? Who needs resources? And also the education and support about communication tips and how to deal with difficult behaviors that often accompany Alzheimer's. We really need to help our clients, and of course the families as well, who are often struggling with this. And then I think the best question we can ask ourselves is, what's the next thing I need to do? Do you have gaps in your knowledge that need to be filled that would be useful to get on a couple of those websites and look around again? Bring yourself up to date on the latest ideas on how to manage difficult behaviors or about assessment and diagnosis. Okay, I'm now going to stop, and I'm going to turn this back to Steve so that he can open up the line for questions and answers, and Mary Alexander can join me.
Thanks very much, Dr. Amy. Great presentation as always. And as you mentioned, we'd like to welcome Mary Alexander to the call from Home Instead Senior Care. Welcome, Mary.
Thank you, Steve, and thank you, Amy.
And as you can see up there on your screen, it's time for the Q&A portion of today's session. So please text in the questions for Dr. Amy and Mary, and we will get to them. The first question, I have a client who lashes out at her husband as if she is scared of him. He does not understand this illness and yells back. How can I help him understand this is a disease? Where can I direct him for help?
I missed the last part of that question, Steve. I couldn't hear the ending.
The ending is, how can I help him understand that this is the disease, and where can I direct him for help?
Mary, do you want to jump in, or you want me to?
You know what? I think maybe we can tag team this a little bit. I think overall, when you just talk about the behavior side of this, the husband does have to understand, and talking through it in a support group setting with other people that are going through this might help him understand this. But again, like Dr. Amy said in the presentation, they're used to having their spouse be exactly the way they have for the last 50 years. And so such a such a significant change in their behavior is it just doesn't make sense to them. So going to a support group and understanding this from a different perspective may help. But also trying to pull back something in their past that the spouse will recognize, a favorite time, a favorite hobby, something, and we call that person-centered. So going back to something that makes sense to the person with Alzheimer's or dementia sometimes can settle a situation down very, very quickly. I was just in a situation where my father was in the hospital for a very long period of time, and during that hospitalization, unfortunately, he was on a ventilator. When he came off the ventilator, he was in a state where he just was incredibly confused to the point where he didn't even know who I was at all, and was very concerned with and very, very agitated that they had to restrain him, and that really bothered me. So as we started kind of talking through his state, and I started to talk to him in a different level and became very calm, we were able to remove the restraints very quickly. However, I had to do things like, my dad was afraid that there were snakes and squirrels in his room, so I was actively taking the squirrels and moving them out of the room, and the doctor and the nurse thought I was absolutely crazy, and they said, "What are you doing? This is all in his mind." And I said, "Yeah, but look, he's not as agitated anymore. I have now solved a problem." So I think taking ourselves and putting ourselves in a different role is very helpful to the person who's agitated. So, Dr. Amy, what do you have to add?
I love that, Mary. I mean, what a great way to have handled that. And it's great because I know as a family member, when I went through this, not so much with my mom because I got used to it after a period of time, her dementia, but I had a similar situation with my dad in the hospital when he got very confused after surgery and was and it must be a common hallucination because he thought there were little animals running around his room as well. And I know when I came in one day and he said to me, I think I've been hallucinating. And I said, "Oh yeah, you thought there were little animals running around the room." And he looked at me and he said, "Well, that was true." And all of his hallucinations, he kept telling me that were true. So I realized he wasn't fully out of his confusion at that point. It took me a minute. I was kind of caught off guard because when people behave this way, they look and sound like the people we love, but they're, it's like someone's taken them over. And that's what's true for the spouses and the kids that we're working with. And that's why I loved your idea, Mary. It's so creative. And I think the key word here is helping families be creative. And one of the fears I think family members have is if they do what you did, Mary, like shooing getting the squirrels out of the room, that they're contributing to the confusion. And we know that's not true. That you can't shake somebody out of this mentally, and you're not going to add to it if they're in that state. What you did was reduce his agitation, which was a fabulous way to deal with it. And I think for this person who's really struggling, I love Mary's idea about the support, going to support group, and also just some simple resources to understand the behavior better will help. And again, that's why I'm recommending those videos on caregiver stress. I also want to recommend David Troxell's book because I think it's a book I recommend to everyone. I think it's fabulous, A Dignified Life, and he's done a fabulous job of really looking, and it's Virginia Bell and David Troxell, at writing a book that's easy for families to understand about those behaviors.
Okay, great. The next question. I have a client who has no family. She has delusions about people stealing from her. How do I validate this, but at the same time convey to her that this can be a sign of dementia? She is also very combative and isolated.
Well, at home instead, we deal with this type of behavior often. And again, there are some simple things you can do to take some steps. First of all, she needs to be diagnosed. So so whoever's helping her needs to go in and get a formal diagnosis. If the clinician or the healthcare professional feels that there's a larger problem there, that's step number one. Step number two then is getting her resources, because if she's still somewhat cognitive, even she's starting down this path, she's still at a place where she can understand that this is going to be a changing disease. And so the other part is that someone needs to help her start to manage her life. It could be a wealth manager at a bank. It could be a trust officer. It sounds like the family member isn't an option, but she can hire a trusted resource to help her with some of that, because unfortunately what we see is those are the most vulnerable adults, and it's pretty easy to get into a situation that could be harmful to her both financially and physically. And so I would say that she's got to put some safety nets into place, first to protect her money and her assets, and second to protect the other assets that she has in her life, like her home and those types of things. But diagnosis is number one.
That's
okay.
Nothing more to add to that. That's absolutely right.
All righty. The next question, what if a client refuses help and their housing comes into jeopardy?
Well, I think Dr. Amy and I have dealt with this a little bit on both ends. And here's the important part. If they're cognitive, there's not a lot you can do. If they're not cognitive and they do have some sort of diagnosis of Alzheimer's or dementia, I mean, there is the step that you can take about adult protective services.
Right.
They do step in. They do help in situations like that. And unfortunately, sometimes that's the route you have to go.
Yeah, and I think that's absolutely right. The flip side of that, and I think that's where Mary was going in this, if someone is cognitively intact, then they may make choices we don't like. So I think this is the difference between whether someone has a cognitive deficit or they're cognitively intact. And so if they have a cognitive deficit, then we have a responsibility to step in, and to make sure that they get the help they need, and that's where the Adult Protective Services through the County Department of Social Services is the route to go. Otherwise, it may just be that we don't like their behavior or a family member doesn't, and that obviously is a different issue.
Okay, here's a scenario. My mother tends to blame others for the consequences of her memory loss. For example, the garbage disposal had some small stones in it and broke, so she blamed a person who was visiting. We tend to ignore the blaming and just fix the disposal. What else could we have done?
Well, we actually talk about, one of the techniques, and again, this is on one of those videos, and it works very well, is accepting the blame when somebody does that. If they have dementia, they are not able to reason correctly. So explaining this in detail about why the person is wrong and that they actually did this will serve absolutely no purpose. So I think the idea of knowing that you have to just say, oh, geez, I'm so sorry that happened. Let's fix that so it doesn't happen again. And, if they have dementia, the truth is that they're not going to likely remember this anyway, depending on where they are in the incident. So it's not worth having a fight about. I think the goal, again, is decrease agitation, decrease the issues, keep the person mentally stimulated, keep a calm environment, and redirect on challenging behaviors. Those are the things, and use the person's life story to create quality of life that we really want families to take away. Mary, what would you like to add to that?
Yeah, Amy, I think you're exactly right there. I too think that sometimes resources for the family caregiver when dealing with these challenging issues is helpful. So I would recommend that you visit a website called helpforalzheimersfamilies.com. Again, that's helpforalzheimersfamilies.com. It's a great site, and it also gives you an opportunity to ask experts questions when you have a particular or a specific issue that you're dealing with.
Amy, earlier you mentioned you plugged a book. Can you give the name of that book again and the spelling of David's last name?
Sure. Oh, boy. Mary's Troxel, Troxel, one L or two L's?
It's one L, yep.
One L, thank you. And it's David Troxel and Virginia Bell, Bell. And the name of the book is A Dignified Life. I've given that to many, many people, and it's been a resource that they have. I mean, there are lots of good books on dementia. I just have had a lot of families really respond positively to that book, and it's very practical and easy to implement, and I think that the resources are great.
Okay, sounds like a good resource. Next question, how would you help adult children whose parents put up resistance to formal diagnosis?
I think there's a couple ways to approach this, and now I'm going to assume we're in fairly early stages here in what I'm saying, and Mary, I'm sure, can add to this because I know Home Instead has some great resources on this. One of the things that sometimes will work with anyone, but with older adults, is if you just say, I know that you feel everything's okay, but I'm worried, and this is causing me stress, and I wonder if you'll do this just, for me. And depending on relationships, a lot of times people will do things for someone they love that they won't do for themselves. So that approach sometimes will work. The problem is there's no one approach fits all on this, but that one sometimes is useful. Pointing out the specific concerns, and this has to be done very gently and in a way that is respectful of the person and not doesn't create defensiveness. But, I'm concerned because here are the things I've noticed. And I want to make sure you have quality of life and that you're independent for as long as possible. And if there is an issue, we want to make sure that we deal with it early. So would you be willing to do this? I think those kind of ways that are not, aggressive and threatening are ways that sometimes work. Mary, do you want to add some things to that?
Amy, I will tell you you are exactly right. I think that the key piece there is communication and just really opening up the way that you as the family member feels. That really helps. Our parents don't want to make our lives more difficult. They want to make sure that we're okay, no matter how old we are. And so just telling them about the fears that you as the child has, talking about how you want to help them maintain whatever type of life that they want, and you're only going to be able to do that with having some open conversations, I think is really the key. Sometimes it'll work, and I'll be honest, sometimes it doesn't. But just trying your best to open up the lines of communication is the best option for everyone involved.
And I think also the idea of asking if as a family member, if you could go to the doctor's visit, with them, or that you will take them. And I think whenever we're approaching any of these situations, the attitude of love and concern and wanting to maintain someone's independence and quality of life goes a long way to difficult conversations.
Okay, next question. I work with several clients with varying ranges of mental impairment, placing volunteers with them to provide services. What are some tips I can pass on to these volunteers that might make it easier for them to build a relationship with someone who may not remember them from day to day?
Again, I would say it goes back to that person-centered approach. When Dr. Amy earlier talked about kind of that life journal or telling the story, putting down some very key facts about that person's past is very helpful. We had a situation where we were dealing with someone who was in the military and for years. He retired from the military. He got to a point where his behavior, unfortunately, his disease progressed pretty quickly, and his behavior was a bit combative, but also we couldn't get him to bathe. We couldn't get him to do things that he needed to do. And so after learning about his history and his life story through his family, we were able to do some things like it had gotten to a point where he needed to take a shower. And so we said to him, look, the colonel is coming today for inspection. We absolutely have to be cleaned up, showered, shaved, ready to go. He instantly got up, went in. We assisted him with the shower. We assisted him with shaving, and he was ready for inspection. The great news is by the time we were able to get him bathed and shaved and dressed, he had forgotten all about the colonel coming, but we were able to get him to do what he needed to do. And so going back into someone's history, something that makes sense to them, is a great way to connect with them, even if it's the same every time that the volunteers go to assist a client that they're working with. That's okay. It's not always the same to the client they're dealing with. It might be to the volunteer, but again, pulling something from their past is probably the best answer that I can give.
Okay. Well, we are just about out of time for today's session. I want to thank our presenters, Dr. Amy Dupree and Mary Alexander for another great web seminar. Thank you very much.
Thank you.
You're welcome.